Hello, my name is Mackenzie Dreyer, and I'm one of the authors and the presenter for the evaluation of diabetic ketoacidosis management in the critically ill children and adolescents. Diabetic ketoacidosis, also known as DKA, is a life-threatening condition caused by an abnormal metabolism of carbohydrates, proteins, and fats. There's not enough insulin with too much counter-regulatory hormones, resulting in an overwhelming production of keto acids, which then exceeds the intra and extracellular buffers, causing a high anion gap metabolic acidosis. In order to meet the criteria for a diagnosis of DKA, a patient must have a plasma glucose level of greater than 200 milligrams per deciliter. They must be in metabolic acidosis with a pH of less than or equal to 7.3 or a plasma bicarb level of less than or equal to 15 milliequivalents per liter. And they must be in ketone anemia, which is a blood beta hydroxybutyrate level of greater than or equal to 3 millimoles per liter, or a moderate to severe ketonuria. Our pediatric patients diagnosed with type 1 diabetes have a 1 to 10% risk of DKA per year, with a 0.7 to 1% risk of developing cerebral edema if they are already in DKA. The pathogenesis of cerebral edema is not fully understood, but the risk is increased for those who have a longer duration of symptoms or who are corrected too quickly. It is our job as researchers and healthcare providers to analyze the protocols set in place in order to prevent these complications that increase the morbidity of our patients. We performed a retrospective chart review to identify the time it took to resolve metabolic acidosis, the amount of fluids, and the amount of insulin used to correct for their dehydration, the total time a patient had spent in the pediatric intensive care unit, the changes in heart rate from both baseline to resolved metabolic acidosis and then from baseline to resolution of their dehydration. And lastly, we analyzed the complications due to DKA and their correlations to ED management. Our population of patients aging from 0 to 17 diagnosed with DKA in the PICU of Spartanburg Regional Healthcare Systems in Spartanburg, South Carolina, utilized a 3-bag protocol in order to correct for dehydration and reverse the process of ketoacidosis. Bag number 1 was a mixture of saline plus potassium chloride plus potassium phosphate. Bag number 2 was a mixture of 5% dextrose plus the contents of bag number 1, and bag number 3 was 10% dextrose plus the contents of bag number 1. The saline mixture for each bag was based on the serum sodium level of the patient. If less than or equal to 140, they received a normal saline mixture, while greater than 140 received half normal saline. The potassium mixture was also adjusted depending on the serum potassium level. Each bag was then dependent upon the patient's blood glucose level. If greater than 300 milligrams per deciliter, they received bag number 1. Level 200 to 300 received bag number 2, 150 to 199 received bag number 3, and if their blood glucose level was less than 150, they remained on bag 3, but their insulin drip rate was cut in half, and if their blood glucose level was less than 80, insulin was stopped altogether. The study contained 247 participants. The majority were within the 13 to 17 age group, female, and Caucasian or African American race. About 98% were type 1 diabetics, and most who presented in DKA had already established a diagnosis of diabetes. The patients spent an average of 1.54 days in the PICU. An average time was calculated for the resolution of metabolic acidosis at 5.98 hours. In order to resolve their dehydration, an average of 114.38 milliliters per kilogram of fluid was used, and an addition of 2.60 units per kilogram of insulin was needed. The average insulin drip rate was run at 0.098 units per kilogram per hour. Based on the simple linear regression model, we found that for every 1 unit of body weight increase, that there would be a 44.78 increase in total IV fluids used in order to correct the dehydration. And for every 1 unit increase in body weight, that there would be a 0.001 decrease in insulin drip rate. But however, there was no significance noted between the amount of total insulin used and the patient's body weight using this model. Then the changes in heart rate were noted from their initial presentation to their resolution of metabolic acidosis, and also from their initial presentation to their resolution of their dehydration. So on average, a patient had a decrease of 35.23 beats per minute from their initial to their resolution of metabolic acidosis, and then a further decrease of 49.64 beats per minute from their initial presentation to their resolution of dehydration. So again, using the simple linear regression model, it supported that for every 1 unit increase from the heart rate at the resolution of metabolic acidosis, that there would be a 0.092 increase in baseline heart rate. But there was no significance in this model noted between the baseline heart rate and the resolution of dehydration. So lastly, complications such as cerebral edema, arrhythmias, and hypoglycemia were analyzed. Each were then compared to either the administration of sodium bicarbonate, the administration of an insulin bolus, or if given 2 or more fluid boluses at 20 mL per kg, or if given any fluid bolus greater than 20 mL per kg. A significant correlation was noted between the administration of sodium bicarbonate and having developed cerebral edema. Research has shown the longer time the patient spends in metabolic acidosis and dehydration will further increase their risk of complications and mortality, the worst being cerebral edema. The 3-bag system used in the PICU of Spartanburg Regional had a quicker resolution of metabolic acidosis compared to other studies with similar insulin drip rates. The demographics of this population were similar to other studies also analyzing children admitted for DKA, although our study population showed an increased incidence of cerebral edema compared to the general population. However, this study does support the common finding that a bolus of sodium bicarbonate correlates with cerebral edema. Thank you.